صباح الخير طلابنا. Our lecture today about the cranial nerves and the autonomic nervous system of the head and neck. I am Dr. Ali Abbas Almusawi, consultant neurosurgeon at Hammurabi College of Medicine. The objective of this lecture is to understand the organization of cranial nerves with respect to their nuclei within the brain, their course through and exit from the brain, and their functional and clinical rules, and to recognize the function and difference between the parasympathetic sympathetic nervous system and be able to link the various parasympathetic ganglia with their cranial nerve counterpart. The 12 cranial nerves all contribute to the innervation of the skin, viscera, and the muscles of the head and neck. Nerves derived from the cervical plexus innervate a portion of the skin of the region. It is essential to understand that the cranial nerves can distribute not only sensory and motor fibers but also autonomic nerves involved within the special sensation like vision and taste. The first of the cranial nerve is the olfactory nerve. The olfactory nerve distributed to the uppermost part of the nasal cavity and is concerned with the smell. It contains only special sensation fibers. It reaches the nose via the cribriform plate of the ethmoid bone. So the fractures of the ethmoid bone involving the dura mater may be associated with the leakage of the CSF from the nose and can cause anosmia, which means a damage to the olfactory system and the loss of smell sensation. The second most important cranial nerve is the optic nerve, responsible for transmitting the special sensory information for the vision. And it is considered a part of the central nervous system, and the examination of the nerve enables us to assess the intracranial health. The course of the optic nerve can be divided into an extracranial, that means outside the cranial cavity, and intracranial component. The nerve leaves the bony orbit via the optic canal and the passage away through the sphenoid bone. It enters the cranial cavity, running along the surface of the middle cranial fossa in close proximity to the pituitary gland. Within the middle cranial fossa, the optic nerve from each eye united to form the optic chiasm, as in the figure. It's very obvious, the optic chiasm. And at the chiasm, the fibers from the nasal medial half of each retina cross over the contralateral optic tract, and the fiber from the temporal half remain ipsilateral. The left optic tract and the right optic tract contain fibers from the left temporal retina and the right nasal medial retina. This is the left optic tract and it's the right optic tract. The right optic tract contains fibers from the right temporal retina and the left nasal retina. The third cranial nerve is called oculomotor nerve. It enters the orbit via the superior orbital fissure and innervates the extrinsic eye muscle except the lateral rectus muscle and the superior oblique. It originates from the midbrain, and it is a mixed cranial nerve containing motor and the parasympathetic fibers. The general somatic efferent fibers of the oculomotor nerve supply the levator palpebrae superioris and the four extraocular muscles, the medial, superior, and the inferior recti, and the inferior oblique muscles. The oculomotor nerve also conveys preganglionic parasympathetic fiber to synapse in the ciliary ganglion, and then provide a postganglionic parasympathetic fiber to the intraocular muscles, enabling the pupillary constriction and accommodation. In this picture, we see the third cranial nerve and the origin from the midbrain and supplying the levator palpebrae superioris and also the superior rectus muscle, the inferior rectus muscle, and the inferior oblique and its connection with the ciliary ganglia. The fourth cranial nerve is called the trochlear nerve. It's a motor nerve, somatic efferent that innervate only a single muscle, the superior oblique muscles of the eye. It emerges from the posterior aspect of the midbrain. It is the only cranial nerve to exit from the posterior midbrain. The nerve travels in the lateral wall of the cavernous sinus and then enter the orbit via the superior orbital fissure, supplying the superior oblique muscle. The fifth cranial nerve is called the trigeminal nerve. It's the great sensory nerve of the head and neck. It's divided into three divisions: ophthalmic, maxillary, and mandibular nerves. The first two are entirely sensory, but the mandibular nerve also contains motor fibers which innervate the muscles of the mastication. The large sensory root and the smaller motor root leave the bones. The motor root is distributed to the muscle of mastication, the mylohyoid muscle, the anterior belly of digastric. The mandibular nerve also innervates the tensor villi palatini and tensor tympani muscles. The ophthalmic branch travels through the superior orbital fissure and passes through the orbit to reach the skin of the forehead and the top of the head, and the maxillary nerves enter the cranium through the foramen rotundum. We see in this picture the maxillary division and the ophthalmic division and the mandibular division of the trigeminal nerve, and we see the origin from the bones and also the foramen rotundum and the superior orbital fissure. This is also the distribution of the sensory branches to the face. We have a mandibular division, maxillary division, and the ophthalmic division. The mandibular division, the sensory part supply the gums, buccal mucosa, anterior two-thirds of the tongue, the floor of the mouth, lower teeth, lower jaw, and chin, and the motor, the muscle of the mastication, and the tensor tympani. The maxillary division, the sensory innervation to the lateral aspect of the nose, upper teeth, the cheek, maxillary sinuses, heart, palate, uvula, and the nasopharynx. The ophthalmic division of the trigeminal nerve, it supplies the scalp up to the vertex. It's obviously in this figure. Forehead, frontal sinuses, conjunctiva, cornea, upper eyelid, and the bridge of the nose. We can do some clinical assessment to this important nerve. So the assessment consists of testing the corneal reflex, testing the sensory division, and testing a motor division. First, we have the corneal reflex, which is also known as the blink reflex, is an involuntary blinking of the eyelid, elicited by the stimulation of the cornea. So the stimulation should elicit a both direct and consensual response, a response of the opposite eye. The sensory limb of the corneal reflex is the ophthalmic nerve, while the motor limb is conducted through the facial nerve, and is very important in clinical practice. Testing the sensory component of trigeminal nerve by testing the three subdivisions of trigeminal nerve. And also we have to test the motor component of trigeminal nerve by having the patient bite down or clench his teeth while the masseter and temporalis muscle are palpated bilaterally. And unilateral weakness will cause the jaw to deviate toward the side of the lesion. The trigeminal nerve may be injured by trauma, aneurysm, or meningeal infections, and the injury to the nerve may cause paralysis of the muscle of mastication that is supplied by mandibular division, with the loss of the ability to appreciate tactile, thermal, or painful sensation in the face, cornea, conjunctiva, and the loss of corneal reflex. The sixth cranial nerve is the abducens nerve. It arises from the abducent nucleus in the bones of the brainstem. It exits the brainstem at the junction of the bones and the medulla oblongata. and travel through the cavernous sinus and enter the bony orbit via the superior orbital fissure. Within the bony orbit, the abducens nerve terminates by innervating the lateral rectus muscle. The seventh cranial nerve is the facial nerve. It's a complex nerve as it contains motor, general and special sensory and parasympathetic fibers. It emerges from the bones of the brainstem and leaves the skull at the stylomastoid foramen. Its motor fibers are distributed to the muscles of the facial expression, as well as the posterior belly of the digastric, stylohyoid, and stapedius muscle. General sensory fibers supply part of the external acoustic meatus and the auricle. The special sensory fibers supply the taste, the anterior two-thirds of the tongue, while the parasympathetic fibers are widely distributed to the gland of the nose, palate, and to the submandibular and sublingual salivary gland. This is the division of the facial nerve. We have temporal branch, zygomatic branch, buccal branch, mandibular, and cervical. And the muscle which innervated by this nerve, temporal branch supplies the frontalis and the orbicularis oculi muscle. Zygomatic branch supplies the auricularis oculi, zygomaticus major, zygomaticus minor, levator labii superioris, and the levator labii superioris elegnazi. And the buccal branch supplies the buccinator and the orbicularis oris. The mandibular branch supplies the depressor anguli oris, the depressor labii inferioris, and the mentalis muscle. And the cervical branch supplies the platysma muscle. We have the 8 cranial nerves called vestibulocochlear nerve or auditory vestibular nerve. It is also transmits the sound and equilibrium from the inner ear to the brain. It's composed of 2 divisions, the vestibular and the cochlear nerve, both purely sensory in function. The vestibulocochlear nerve carries special somatic afferent fiber from the structure of the inner ear. The cochlear nerve enables the sense of hearing, while the vestibular nerve is responsible for the sense of balance. The cochlear nerve arises from the organ of Corti, which lies in the cochlea of the inner ear. The cochlear nerve enters the internal acoustic meatus, where it joins with the vestibular nerve, and they form the vestibulocochlear nerve, and then enter the brainstem in the cerebellopontine angle along with the facial nerve. So the vestibulocochlear nerve is one of the most important cranial nerve involving clinically by what's called cerebellopontine angle tumor. A tumor arising from this region may damage the vestibulocochlear nerve. The 9th cranial nerve is the closopharyngeal nerve. It exists from the medulla oblongata and contains 4 types of nerve fibers. Motor fiber supplying the stylopharyngeus muscle, parasympathetic fiber innervate the parotid gland, fibers of special sensation innervate the posterior third of the tongue, and the general sensory fiber are widely distributed to the pharynx, oropharynx, dorsum of the belly, the auditory tube, and associated structure, the mastoid interum and the mastoid cells. And finally, via its sinus nerve branch, it supplies the carotid sinus and the carotid body that monitor the blood pressure and the arterial oxygen level respectively. The 10th cranial nerve is the vagus nerve. It has enormous territory extending into the abdomen. In the head and neck, it's sensory to the lower part of the pharynx, the airway, and the esophagus, and to provide general sensation, and the parasympathetic and motor fiber to the lower part of the pharynx. So it is a motor to all of the pharynx except the stylopharyngeus, to the larynx, trachea, and the esophagus. In addition, it supplies all of the palate muscle except the tensor villi palatini. It supplies taste fiber to the taste bud associated with the epiglottis, and it is essentially to external auditory meatus and the back of the auricle. It leaves the skull through the jugular foramen. The 11th cranial nerve is the accessory nerve. It has a cranial part and a spinal part. The cranial root is accessory to the vagus by providing part of its motor component. The spinal root of the nerve contains fibers from the cervical 2, 3, and 4 spinal nerve, and it innervates the sternocleidomastoid and trapezius muscles. Current evidence suggests that the spinal root contains both sensory and motor fibers, and also it passes through the jugular foramen. The 12th cranial nerve is the hypoglossal nerve. Is a motor to all of the muscle of the tongue with the exception of the palatoglossus muscle. Some cervical nerve from the cervical 1, 2, 3 spinal nerve are looped onto the hypoglossal nerve, forming the ansa cervicalis, and these fibers are distributed to the strap muscle of the neck, and it leaves the skull through the hypoglossal canal near the foramen magnum. The hypoglossal nerve passes inferiorly, as in the figure, to the angle of the mandible, crossing the internal and the external carotid artery. The hypoglossal nerve crossing both internal and the external carotid artery to the direction to enter to the tongue. The hypoglossal nerve is responsible for motor innervation of the vast majority of the muscle of the tongue, except for palatoglossus. This muscle can be subdivided into two groups, extrinsic muscle and intrinsic muscles. As in this picture, we have extrinsic one, genioglossus, hypoglossus, styloglossus, and the palatoglossus, which is all innervated by the vagus nerve. Intrinsic muscle of the tongue includes superior longitudinal, inferior longitudinal, transverse, and the vertical muscles. This is the base of the skull with important foramina through which the cranial nerve passes. We have cribriform plate, the olfactory nerve passes through these foramina. Optic canal for the optic nerve, and we have superior orbital fissure through which the oculomotor, trochlear, ophthalmic, and abducens division of trigeminal nerve passes through. We have a foramen rotundum within the middle cranial fossa. The maxillary division passes through it, and we have a foramen ovale. The mandibular division of trigeminal nerve passes through it. And we have internal acoustic meatus, the facial nerve, and the vestibulocochlear nerve pass in this opening. And we have jugular foramen, which is near the foramen magnum, through which closopharyngeal, vagus, and accessory pass. And finally, we have the hypoglossal canal, through which the hypoglossal nerve pass. We have another important subject related to the cranial nerve. It's autonomic innervation of the head and neck. We divide it into the sympathetic and the parasympathetic division. First, we have sympathetic system. The action of the sympathetic nervous system are associated with the fight or flight response. The sympathetic fibers to the head and neck begin in the spinal cord. They originate from the thoracic region from T1 to 6, and therefore need to ascend to reach the structure in the head and neck. After leaving the spinal cord, the fiber enters the sympathetic chain formed by the nerve fiber and ganglia, and there are 3 ganglia within this chain that are of interest: superior, middle, and inferior cervical ganglia. We have the superior, and we have the middle and inferior cervical ganglia. The superior cervical ganglia, several important postganglionic nerve fiber originate from here: internal carotid nerves, external carotid nerves, nerves to the pharyngeal plexus, superior cardiac branch, and nerve to cranial nerve, 2nd, 3rd, 4th, 6th, and 9. Gray rami communicant distribute sympathetic fiber to the anterior rami of C1 to C4. We have middle cervical ganglia. The gray rami communicants distribute sympathetic fiber to the anterior rami of cervical spinal nerve 5 and C6. We have thyroid branches and middle cardiac branch. And we have the 3rd ganglia is inferior cervical ganglion. the gray rami communicants distribute sympathetic fibers to the anterior rami of C7, 8, and T1. And we have branches to the subclavian and vertebral arteries and inferior cardiac nerve. The inferior cervical ganglia is a small ganglion and may combine with the first thoracic ganglia to form the stellate ganglion. This is the main differences and anatomical distribution of sympathetic and the parasympathetic. Sympathetic system can dilate the pupils, whereas the parasympathetic can cause meiosis or constriction of the pupil. It can weak stimulation to the salivary gland by sympathetic, whereas in parasympathetic we have strong stimuli of the salivary flow. Clinical relevance to the sympathetic involvement, what is called a Horner's syndrome. The sympathetic fiber can be stretched or damaged along their course to the head and neck. And if these nerves are unilaterally disturbed, it produces a triad of main symptoms known as a Horner syndrome: partial ptosis, meiosis, and anhydrosis. And we have this picture in case what is called a Pancoast tumor involving the sympathetic chain. And in this picture, we can see the feature of the Horner syndrome, the meiosis, ptosis, and anhydrosis. This is also, as we said previously, the division of ganglia to the superior cervical, middle, and inferior cervical ganglia. The next, another component of autonomic nervous system, we have parasympathetic innervation of the head and neck. The action of the parasympathetic nervous system are associated with the rest and digest response. There are 4 pairs of parasympathetic ganglia in the head: 4 cranial nerve, the oculomotor, facial, closopharyngeal, and vagus, have brainstem nuclei containing preganglionic parasympathetic neurons. But only 3 of these nerves have branches that reach the ganglia. The vagus nerve does not have. Ciliary ganglia with the oculomotor nerve, the pterygopalatine ganglia with the facial nerve, the submandibular ganglia with the facial nerve, and the otic ganglia involved with the closopharyngeal nerve. First, the ciliary ganglion lies in the orbital cavity, lateral to the optic nerve. The parasympathetic fiber are derived from the oculomotor nerve and passed to the sphincter papillae and ciliary muscles. Sympathetic fiber come from the superior cervical ganglia by the plexus on the ophthalmic artery and are distributed to the eyeball. Sensory fibers from the eyeball pass to the nasociliary nerve. This is the sympathetic and the parasympathetic innervation, and the 4 parasympathetic ganglia: ciliary ganglia, pterygopalatine ganglia, and otic ganglia, and the submandibular ganglia. The pterygopalatine ganglia lies in the pterygopalatine fossa. The parasympathetic fibers are derived from the facial nerve via the greater petrosal nerve, and the postganglionic fibers supply the lacrimal gland and the gland of the nose, palate, and the nasopharynx. Sympathetic fibers come from the superior cervical ganglion via the plexus on the internal carotid artery. The fibers are distributed to the nose, palate, and the nasopharynx, and the sensory fiber from this area pass in the branches of the ganglion to the maxillary nerves. The submandibular ganglion is suspended from the lingual nerve by small branches. It is parasympathetic fiber come from the facial nerve via its chorda tympani branch and then along the lingual nerve to the ganglion. Postganglionic fibers supply the submandibular and sublingual glands and other glands in the floor of the oral cavity. Sympathetic fiber come from the superior cervical ganglion along the facial artery and pass to the gland in the floor of the oral cavity. Taste fiber may pass through the ganglion. The parasympathetic fiber to the otic ganglion come from the closopharyngeal nerve and pass within the auriculotemporal nerve to the parotid gland. Sympathetic fibers come from the superior cervical ganglia along the middle meningeal artery and pass to the parotid gland. The parasympathetic fibers to the otic ganglia come from the closopharyngeal nerve and pass within the auriculotemporal nerve to the parotid gland. And sympathetic fiber come from the superior cervical ganglia along with the middle meningeal and pass to the parotid gland. And the motor branches from the mandibular nerve pass through the ganglion without synapsing. The parasympathetic fiber from the closopharyngeal nerve supply directly or through pharyngeal plexus, the glands of the oropharynx and the posterior third of the tongue. Parasympathetic fibers from the vagus supply the gland of the laryngopharynx, larynx, esophagus, and trachea. In all these cases, the ganglion cells are on the viscus. So injury to the sympathetic trunk, as we said previously, or ganglia in the neck or upper thorax result in the following disorder on the affected side: pupillary constriction, drooping of the upper eyelid ptosis, flushing of the face, and the leg of sweating. And thank you.